Greetings to everyone. Today we shall have a quick session on acne, or what you call pimples, this common disorder affecting teenagers with the age group between about 8 to 35 years. And it is quite disturbing, having all possible side effects, including psychological effects, things like even depression and anxiety, because of what it comes with. So today we shall debunk the knowledge behind acne, how it comes about, the best way to manage it, and how to approach a patient who presents with this disorder. So as you can see in this picture, we see a patient having different swellings. I'll first call them swellings. On the forehead, someone has similar lesions on the face, someone has other lesions also on the back. So acne can have various presentations, and it is very key for you to note the different way it can present like and things that can mimic how acne presents like. So to start with, acne is a multifactorial disorder that affects the pilosebaceous unit that includes the hair follicle together with the adjoining sebaceous glands. So that constitutes the pilosebaceous unit. So acne has an effect on someone's psychology, on how they think, on how they feel, or how they perceive themselves. And some people have ended up actually missing opportunities, thinking that maybe the acne they have is the reason why they have missed such opportunities. So in the clinical presentation, commonly we have primary lesions we call comedons, which I would see how they look like and how they come about. We can have papules, pustules, cysts, as well as other things like scarring. And commonly it comes during the process of adolescence. So it can start as about 8 to 7 years, but most commonly around 11 and 12. Then it will go through someone's life all the way up to around 25 to 35, depending on someone's hormonal basis. And what you have to understand is that since it is occurring in this very fragile age group, people who are very concerned of their appearance, how they look like, it should be managed properly to avoid other things like anxiety, to avoid other things like depression, social withdrawal, and the dire effects of hyperpigmentation, scarring that comes with acne. And what you have to understand is that different research is being done to refine the understanding about how it comes about, the different subtypes, and how to optimize treatment in this particular condition. So when you go to how common is this acne? So acne was first described, and this word was originated in around the 16th century by Amidenus, who first described it and called it the word acne, and it went all the way through to be separated from rosacea. Also rosacea affects the face by Erasmus Wilson in the 1842. It affects about 40 to 50 million people globally, and in the US, and this could be even bigger depending on the location that you're looking at. 80% of the patients with acne are aged between 12 and 24 years. So this is a very, very key age group. And it can persist in 35% of women to go up to their 30s, or up to even about 35, or even late or early 40s. So there are some risk factors that increase the risk of having acne. So genetic factors that, like patients who have this karyotype XYY, meaning that they have two Y chromosomes, so they end up having more of the female hormones, and then other endocrine disorders like PCOS, the hyperandrogenism. So all these can contribute to the exacerbation of acne. So every time you see someone having these pimples that are not going away and they're very, very severe, you also need to do baseline hormonal profiling. We also have a genetic contribution because there's a high concordance amongst identical twins. And sometimes there's even a family history of, say, a particular type of acne, like the acne conglobata. It tends to run in families. And it has also been associated with some particular foodstuffs, especially. Examples including milk, especially the skimmed milk, high glycemic diets, like those foodstuffs that raise your blood sugar immediately after taking like the sodas, those foodstuffs with very high glucose content. And other things like vitamin B12 supplementation may also exacerbate acne. So going forward, when you look at how acne comes into existence, it usually has three mechanisms, and these are very clear and very easy to understand. So the first one is what we call follicular hyperkeratinization. So if you have a hair follicle, the skin or the epithelium or the epidermis surrounding the hair follicle undergoes hyperkeratinization, forming a lot of dead cells, what we call keratinocytes, all along with keratin. So all these contribute to the initial lesions, as we are going to see. Then the second factor that plays a very significant role is the hormonal influence, especially on the sebum glands. So all the sebaceous glands, so this hormonal influence increases the production of this sebum. So overproduction of the sebum coupled with follicular hyperkeratinization contributes to the blockage of the hair follicles, giving rise to the initial lesions that you see in acne. Then the last factor is the hormonal response or the immune response to the bacteria, Propionobacteria acnes, and this also plays a very important role in the worsening of the initial lesions of acne. So what you have to understand is that the sebaceous unit is very key in the pathogenesis, and you have to understand that it is composed of the hair follicle together with the adjoining sebaceous gland. And essentially, we know that the sebaceous gland produces sebum, which is a normal moisturizer of the skin with lipids and proteins that also act as the innate immune system of the skin, having the antibacterial effect and also having antifungal effects. And it is very important for you to remember that the production of this sebum is well regulated by the body's hormones. So when you are dealing with acne, you have to make sure that when you are treating, you address all the three factors. So if you are to discuss one by one, what happens in follicular hyperkeratinization? So in this case, you have the initial formation of what we call the microcomedon or the microcomedon. So in this case, you have dead skin or what we call keratinocytes together with the excess keratin. And in this case, they will come together and aggregate and form a follicular plug that will block the exit of the hair follicle. So that will be like the initial process of what happens. Then you'll have interleukin-1 alpha being produced, and this will stimulate proliferation of keratinocytes around the hair follicle. So this keratinocytes that are being produced at a higher rate with a high turnover end up clogging the hair follicle to give rise to the initial lesions that we call the microcomedons. So as this progresses after getting this blocked follicle, then you'll have now other factors coming into play. So if you have now increased sebum production, sebum is being produced, but it has no way through the hair follicle. So it will now accumulate below the hair follicle, now giving rise to what we call the comedons or the initial lesion that we call comedons. So in this case, we have to now to understand also the role of how does that sebum come into play. So we have hormones that increase the sebum production, and these are the androgens, especially the dihydrotestosterone. This one includes sebum production. So as you're having increased androgens in your body, they will stimulate the sebaceous glands, leading to increased production of sebum, which will usually give you an oily skin. So this is a very important factor because you see that people with oily skin, they stand a very good risk or a high risk of developing acne. And we usually have hormonal changes across the different stages of life. We know that your androgens are usually produced very early in life during the period of infancy. You have a fast surge of androgens in your body, but as the child goes through the first 2 years, that androgen production almost goes to zero, just rise again later on as they start their adolescent during their adrenergic period, which is around 7 to 8 years. So that's why we can start seeing these pimples or acne more commonly, even as early as maybe 7 to 6 years. So this estrogen that goes high is very, very key as well, because estrogen also has a negative effect on sebum production. That's why in some cases where someone has hormonal acne, we end up supplementing them with oral contraceptives with the target of them getting more estrogen in the body, which counteracts the effects of the androgens, the effects of the testosterone-derived hormones. So then we have the role of inflammation and propionobacteria in the progression of acne. So in this case, we have inflammatory markers, as we've mentioned earlier, like interleukin-1, the CD4 cells. These usually accumulate even near the hair follicles, even before the hyperkeratinization. But how they come about to rise in the initial lesions, that is not well understood. But what you have to understand is that the acne lesions caused about by different cells. Usually the pustules are caused about by the accumulation of neutrophils. And then if you have other things like the papules, the nodules, and cysts, these ones are usually formed by accumulation of the T cells and the giant cells like macrophages within the acne lesion. So when they come, they are very destructive, and then they end up giving you the papules, nodules, and cysts as well. So when you look at P. acnes, that bacteria that we usually treat in acne. This is treated because one, in normal people, it is just a normal flora, but sometimes it can also tend to be pathogenic. So it can stay on your skin without causing problems. But if you have a risk of forming acne, if you have oily skin, then this bacteria also plays a role in exacerbation of acne. And it does this by producing lipases and also stimulates the antigens on the bacteria, stimulates production of cytokines and activation of the immune system, because it will activate what we call the toll-like receptors, or especially the toll-like receptor 1, 2, and 4. So when you stimulate these toll-like receptors, you are activating the innate immune system in the skin. That means that you're activating the CD4 cells, you're activating the neutrophils, you're activating the cytotoxic T cells that will come around and try to eliminate the bacteria. Then this P. acnes also activate what we call the node-like receptor protein 3, and all these are pro-inflammatory mediators that end up stimulating or complicating acne by producing more inflammation. And what you have to understand is that in this case, initially you had hyperkeratinization, which caused the blockage of the hair follicle. After that, then someone has a hormonal input. They have stimulation by the androgens, especially the dihydrotestosterone hormone that stimulates the sebaceous glands, leading to production of more sebum. So at the end of it all, then the P. acnes comes in to act as a trigger of more inflammation within the acne lesion. So you end up having the development of the overt acne lesions. So in this illustration, I try to show you how each of these comes about. So in the early process, when you're forming acne, we have what we call the early comedon, or what we call the microcomedon. So the formation of this, usually in this case, you've not yet had the interplay of either hormones or even the P. acnes, but you just end up having increased proliferation of keratinocytes and deposition of coniocytes within the opening of the hair follicle, as you can see here. So this is the opening of the hair follicle, as you can see here, and then you have these cells that are along the canal or of the hair follicle that undergo hyper proliferation. Then they end up blocking the exit of the canal, and this has been associated with early, even before it comes into play. We have increased interleukin-1, and then also increased stimulation of the sebaceous glands by the androgens. So after you've now blocked this exit, that means that you are producing your sebum from the sebaceous glands, but it has no way through. So now it will clog. It will cause now a clogging of the hair follicle, and then you have now this distension that we are seeing here. Now, Then you'll have now the invasion of the bacteria, the P. acnes, and I think you see it there in blue. Then because of this, you'll now trigger an immune response. So that's when you end up with inflammatory acne that will either give you the papule, the pustules, the nodules, and the cysts as well. So the P. acnes will also now upregulate the innate immune system. We say that it will activate the toll-like receptors, and in that the toll-like receptors are located on the macrophages, on the neutrophils, on the resident cells of the keratinocytes, and once stimulated, it is an idea that you have an invasion, have an infection that needs to be dealt with. So your immune system will wake up and then try to get rid of this P. acnes. So that's how you'll end up now forming the papules, the pustules, and later on the nodules and cysts. So in this case, as you can see here, now the P. acnes has multiplied because it also feeds on the sebum that your body has produced. So it's now more P. acnes, more stimulation, then you end up with forming this type of lesions, as you can see here. So now at the end of it all, the once well circumscribed maybe lesion, it will burst into the epidermis. So meaning that the inflammation now be spread to go under the surrounding skin. And at the end of it all, that's where you end up forming cysts with pus. That's why you will form very big nodules when you have now this bursting. So that's how the progression will be. So just to summarize for you, when you're talking about how acne comes about, remember the three things that we've discussed. The first one, you have hyperkeratinization, which results into blockage of the hair follicle. Then the second one, you'll have the hormonal contribution, where you'll have increased production of androgens that stimulates the production of sebum from the sebaceous glands, increasing the oil in the skin and increasing the oil in the hair follicle. That will later be invaded by the P. acnes that will now stimulate your innate immune system to give rise to the inflammation that we see in acne, to give rise to those nodules that we see in acne, the papules, and the rest. So that's how you can remember it. And then remember, we have key cytokines that play a role, including interleukin 1 is very, very key in the pathogenesis of acne, as well as the CD4 cells. So you have to remember those type of cells, and then the toll-like receptors and the nodule-like receptors that are activated by the P. acnes to give rise to the immune response that we see in acne. So to summarize for you, now this is a flow chart that tries to show you the hormones that play a role in acne. Usually we start with this DHEA, or what you call there. So this is the androsterone that is usually produced in the body, circulating in the body, but then it is converted it is a very weak androgen, but it is converted into testosterone, and then testosterone can now further be converted to a more potent androgen that stimulates the sebaceous glands, the dihydrotestosterone. So this is very, very key because when you now have a lot of this hormone, the dihydrotestosterone, it will now stimulate the sebaceous glands, giving rise to a lot of sebum, producing a lot of sebum. So you end up with a very, very oily skin. So that is why it is very key for you to give drugs or to manage acne after evaluating whether there's a very big contribution of hormones or no. If you are examining a patient for acne, you have to look out for other features of increased androgens in the body or other features of other hormonal disorders like PCOS. Like you have to look now for the male pattern distribution of hairs, the deep voice, then you have to do an abdominal scan to see that they don't have polycystic ovaries. So at the end of it all, you now know how to manage depending on what is causing the acne. So in the clinical features, when you're looking at acne, the commonly affected areas are the areas that have a lot of sebaceous glands. And that's what we call the seborrheic distribution. So those areas usually include the face, the chest, the back, the upper arms, and you find people having a lot of acne in those particular areas. Then the types of lesions can either be classified as either non-inflammatory, meaning that you just have only the comedones before the invasion of the acnes to complicate the entire picture, So in that case, the comedones, or what you call comedonal acne, is also having two types of lesions. It's either closed comedones. In this case, we also call them simply the whiteheads. And usually it's a very small skin-colored bumps on the skin, but they don't have a punctum on top. Then when they get a punctum, usually this sebum that is inside will undergo oxidation and it will turn black. So it will be now the open comedones, or what we call the blackheads. And someone you see now a dilated pore, enlarged pore with dark oxidized keratin plug. So that's what we call the open comedones. Then we also have what we call the inflammatory acne. So the inflammatory acne will now have the inflammatory lesions that we talked about. We'll have the papules, the pustules, the nodules, as well as the cysts. And in case you have inflammatory acne, there's a high risk of forming scar tissue. So you have to manage it more aggressively so that someone doesn't get a risk of getting a scar tissue as well as hyperpigmentation. So as you can see in this picture, I try to show you a mild form of acne, or the way how it will look like in this skin. So the papules that we see here, that these are now what we call comedones that are closed. So they are also called whiteheads. Now these ones that have black punctum, those are the ones that we call open comedones, also called blackheads. And in this picture here, you'll see that someone has different types of lesions. Now this is a white comedone, white comedone, white comedone, white comedone, white comedone. And then this particular individual also had a few papules. So that is now a comedonal acne. Now this one is the inflammatory acne. So in inflammatory acne, we get things like cysts, like as you can see here, you can get nodules, then there's an erosion, you get papules, pustules. So that is now inflammatory acne. So you can find some individual having either inflammatory acne or non-inflammatory acne. So that classification is also very key for you when you're managing, because they are different and you deal with them differently. So let's look at the variants of acne, or the different ways it presents. I will start with the post-adolescent acne, which usually occurs in women who have already finished their adolescence, but now they have an onset of acne, usually above the age of 25 years. So it is also similar to what we see in adolescent acne, but just the difference is the late onset, and oftentimes the lesions are common on the jawline or the mandibular area around here, and they'll have a mixture of either inflammatory or non-inflammatory acne lesions. So in this case, we will see patients presenting with either papules, pustules, nodules along the jawline. So some patients, it can be a persistence of just the normal acne. So maybe they had acne during their adolescent period, but now it persisted to go with them into the post-adolescent years. So 50% of the cases, most of them had acne early, but the other percentage, they just didn't have acne, but it just had a late onset. So commonly, this type of acne is associated with flares, especially during the menstrual cycle. And every time either it is before or during the cycles, they get a flare. Then after that, the face almost clears. Then the next month, the same thing happens. So it also has a very good contribution from the hormone aspect. That's why it can have that cyclic patterns. And 20% of the patients with this post-adolescent acne, oftentimes they have irregular cycles, and they can have other hormonal disorders like hyperandrogenism. They can have hirsutism, and then also they can have other things like androgenetic alopecia. So adult onset, we can also have it acne occurring actually after even this period of time, like above 35, above 40, then patients have acne. So that will be like an adult onset type of acne. And predominantly, it is usually comedonal. It has been associated with smoking, but the pathogenesis is also not yet clear. So when you go to another very bad type of acne, what we call acne fulminans, and this one usually affects a little bit of the adolescents in age group of around 13 to 16 years. And it is a very, very severe type of acne with an acute onset. Someone can have maybe pre-existing lesions, but then they have a very, very bad flare that can even claim their life if not well managed. So in this case, someone will have severe sudden onset nodular acne with systemic symptoms, including things like fever, including things like joint pains, malaise, and they can actually end up being what? Admitted, because they can be even septic. So commonly seen in boys aged 13 to 16 years. And in the clinical picture, someone will have, as we've said, rapid development of very painful inflamed oozing plaques that sometimes can be hemorrhagic. They can be on the face, the neck, the back, the trunk, and as well as the arms. So they can also get ulcerations, and it also comes with very, very severe um, scarring because of the nature of the lesions that they get. Then when you go to the systemic symptoms, as I had mentioned, they'll have a very high grade fevers, joint pain, muscle pains, malaise, and sometimes they can even end up getting lytic lesions involving the clavicle, involving the sternum because of the involvement. So they end up with some form of osteomyelitis, emerging from acne. And some patients have also been seen to report lesions that are similar to erythema nodosum. So in the treatment, this is the form of acne that requires you to admit the patient, then you give prednisolone, and in prednisolone you can give a dose ranging between 0.5 to 1 milligram per kilogram body weight per day for about 2 to 3 weeks. And then you start isotretinoin, but at a low dose. So in this case, when you're starting your isotretinoin, you start at the lowest possible dose. You can even start with 10 milligrams per day. Then as someone tolerates, you can now increase the dose of isotretinoin as you reduce the dose of the oral prednisolone. So we use prednisolone to try and calm down this acute inflammation and minimize the side effects like the scarring and the rest. Then additional options, you can also give intralesional steroids, if or topical steroids, if the lesions are a little bit localized. And you can also give other drugs like the tumor necrosis factor inhibitors and other immunosuppressants like cyclosporine. And dapsone can also be used in case the patient has erythema nodosum. So this acne fulminans is very, very severe. It's a severe type of acne that needs to be addressed very, very fast because it progresses very rapidly and it has dire or very, very severe effects. Then we go to the next one, we call acne conglobata. So acne conglobata is also another form of severe acne. So in this case, the patient will present with very severe chronic form of nodulocystic acne. It can also have an abrupt onset, and in this case, the difference with fulminant, in this case, you don't have systemic involvement, so they will have no fever, no other systemic involvement. So it can also be part of what you call the follicular occlusion triad, and this triad includes things that have terminal hair involvement, and they occlude the hair follicle. So that follicular occlusion triad has acne conglobata. It has the dissecting folliculitis of the scalp. It has the hidradenitis suppurativa that affects usually the axilla, and then it also has the pyronidosis, or commonly seen in the sacral areas or the lower back. So acne conglobata is also associated with different syndromes, and these syndromes includes the Papa syndrome, which is an autosomal dominant disorder. And the Papa syndrome has these features. It has the polygenic, also the pyrogenic arthritis. So someone has past discharge from the joints, like especially the knee joints, the ankle joints, and then also around the elbows. You can get pyrogenic arthritis. Then they will have the pyoderma gangrenosum, which is a neutrophilic disorder, presenting with that characteristic lesion, that ulcer that starts from either papule, then erodes to give you a very big ulcer in a very short period of time. Like within 2 weeks, the ulcer is more than maybe 2 centimeters in diameter, very, very big, rapidly progressing. Then the other feature is the acne conglobata. So the Papa syndrome, so the patient will have those 4 disorders: the pyrogenic arthritis, pyoderma gangrenosum, acne conglobata, occurring together at the same time. It has been associated with a mutation in this particular gene, the PSTPI1, gene, and it is an autosomal dominant disorder, meaning that if the parent had, since it is dominant, it will be manifest in the child. Then other syndromes like the papash have also been associated with acne conglobata, but in this case, you'll have suppurative hidradenitis or hidradenitis suppurativa, also complicating the situation. That will be now the papash syndrome or the pash syndrome. So in the pash, you'll have virginic granuloma, the acne conglobata, and then the hidradenitis suppurativa. So those are the syndromes that have been associated with acne conglobata. So every time you see acne conglobata in a patient or when you make that diagnosis, you have to screen and rule out the other comorbidities that can occur in conjunction with acne conglobata. And it has also been associated with other conditions like inflammatory bowel disease. And sometimes this can complicate now the treatment with either tetracyclines or even isotretinoin, because now in inflammatory bowel disease, you don't want to give these drugs. So it can be a little bit tricky when you're managing. Then we also have this, what we usually call the solid facial edema, also called the Morbihand disease. So sometimes you can get an induration or edema, which is like even hardwood on the face following acne. So sometimes it may be acne or even other conditions can give you something similar, but it is a rare disfiguring complication of acne, and we get that midline facial swelling, which is which will give you that hardwood induration, and primarily it can affect the cheeks, as you can see in this picture. So someone has this swelling and edema of the subcutaneous tissues following acne. So it has been linked to chronic inflammation, and this chronic inflammation that we see in acne ends up causing the pharyngitis, which we call inflammation of the lymphatic vessels that are supposed to drain lymph from the face. So because of that, then you have accumulation of intercellular fluid that ends up giving you edema because of the blockage or the of the lymphatics that are supposed to drain the lymph from the face. You can also have there's also a link that has been attributed to mast cells and the genetic factors, but this is still not yet confirmed. And other associations have also been this Morbihand disease has also been seen in patients with rosacea. We know rosacea is a vasculitis that occurs on the face, giving you those acne-form lesions. And also because of the inflammation that comes with it, you can end up occluding the lymphatics, giving you this edema. Then in treatment, we usually give isotretinoin to try and remove all the residual acne. And then sometimes you may need to extend this phase of treatment for about even 2 years. And sometimes you can add ketotifen or even prednisolone to try and enhance the results, because these are now anti-inflammatory drugs that will help you calm down the inflammation that comes with acne and also rosacea. So moving on forward to the different types of acne, the other one that we usually see is what we call the neonatal acne. So in the neonatal period, also these young ones can also have acneiform lesions, and commonly it affects up to even 20% of the newborns appearing around the second week of age, and then resolving by 3 months. So characteristically, someone will have small papulopustules, but they don't usually have comedones, primarily affecting the cheeks, the forehead, the eyelids, and around also around the chins here. And it can also be scaring to parents, saying that how can my child have acne at this time? And the difference is that this type of acne, or what we call neonatal acne, has nothing to do with the P. acnes. It is commonly thought to be due to like an abnormal immune response to the colonization of the Malassezia species, especially the Malassezia fafa and then the spondylitis, or these other species of Malassezia. So as immediately after birth, when the child comes out, usually their skin is sterile with no bacteria. So after that, they end up picking bacteria and fungus from their parents as you're breastfeeding the child, as you do skin to skin contact, the child picks up this normal flora from the parents, then they can have an abnormal immune response, especially to the Malassezia species, to give rise to what we call the neonatal acne. So some people have linked it to active sebaceous glands and high sebum production in the newborns, driven by the androgens that usually come from the mother. And in the management, this is the self-resolving. You don't need to worry. You just reassure the patient. But in case they are very, very worried, you can give a topical imidazole, maybe like ketoconazole, 2% cream, for a very short period of time, like 1 or 2 weeks, and the child will be fine. So we also have now another category. This is now age group based, the infantile acne, commonly occurring between about 2 months to 12 months of age. Someone can get a little bit of some comedone formed with potential for either deep nodules and then also pitted scarring. And this is thought to be driven by the androgen production, including the elevated luteinizing hormone induced by testosterone in boys in the first 6 to 12 months, and also the DA production, which comes from the adrenals of both boys and girls. Remember, in the pathogenesis, we talked about the role played by these hormones, especially the dihydroestrogen, the DHEA hormone, playing a very big role. So remember, you said this one, DHEA is a very weak androgen. So, but what you have to understand is that within the sebaceous gland, since we have the aromatase enzyme, the aromatase enzyme can convert it into the active testosterone or the dihydrotestosterone, which ends up producing, stimulating production of this sebum. So in the infantile acne, there is a pathogenesis that lies within that line of increased production of androgens. So in this case, when you're doing evaluation, you have to check for hyperandrogenism, early puberty, or what you call precocious puberty, abnormal growth is present. Then you have to do hormonal, and then also bone age assessment to see if there's any other underlying disorder. But usually, if there's nothing underlying, this type of acne also resolves by itself in about 6 to 18 months, but sometimes can recur when they click adolescence, and in that case, you manage as the rest of the acne. The first line treatment in this case, you have to give the topical retinoids, including tretinoin, adapalene, but you can also use the benzoyl peroxide. But in severe cases, you can also add a few oral antibiotics like septrin or even azithromycin. Remember, in this age group, we don't use tetracyclines because of the side effects that they can also damage the teeth in this particular age group. So below 8 years, you cannot use the tetracyclines. So the other one, we have what we call the mid-childhood or pre-adolescent acne. So in this case, it affects children in about 1 to 7 years. It's a little bit rare, but you have to evaluate still for hyperandrogenism, premature adrenal or even congenital adrenal hyperplasia, or even androgen secreting tumor. So when you see this type of acne in these children, you have to now to assess and see, is there any tumor that is secreting androgens somewhere, maybe in the brain or anywhere in the body. So you have to assess them a little bit more. But still, if you have assessed and there's nothing else, you can also treat with the topical retinoids and then benzoyl peroxide. We also have what we call the pre-adolescent acne that is now from 7 years around 11. Commonly it is comedonal, and loves the T-zone, this zone here, the T-zone of the face. And in this case, you have to consider PCOS if the child is female, or any other endocrine issues in case it is severe and complicated. So when you see acne in children, basically you have to make sure that you do their hormonal profile to see that they don't have any underlying hyperandrogenism issue or any. Then you have to now to hunt for any possible tumors that can be secreting the androgens. So then you have this other type of acne, that one we call acne scoriae. So this acne scoriae is also classified under psychocutaneous disorder because someone ends up picking on all the acne lesions even before they come. So when they present to the clinic, you'll find they don't have any active acne lesions, but they'll have either post-inflammatory hyperpigmentation, they'll have scars, they'll have eroded papules, they'll have ulcers, they'll have wounds, but they will not have any primary acne lesions because of the frequent picking on acne lesion. So we classify it as one of the uh, uh, obsessive compulsive disorder or even body dysmorphia. Like they think that uh, the acne actually makes them look bad. So what they do, they deal with each lesion as it appears. So this type of acne is one of the acne that you have to manage together or in conjunction with a psychiatrist. And we take it as one of the severe type of acne, and we use isotretinoin to manage it together with other antidepressants or other antipsychotic medicines like selective serotonin inhibitors, such that these patients calm down. You have to deal with their anxiety, their other psychological needs, such that you also get rid of this type of acne. Because if you don't, they'll never stop picking on this acne. Then we also have this acne that can come with uh, uh, endocrinological abnormality. So sometimes patients can have hyperandrogenism. So you have to look for the signs, like if someone has acne, has asceticism, has irregular cycles, has a deep voice, then has a muscular buildup, and then you see that these patients also have other things like hair and syndrome, where you have hyperandrogenism, insulin resistance, and then acanthosis nigricans. So you have to assess all these conditions to make sure that you address each and every one of them. So this is the keynote you can pick from here. So if you have a patient of acne, but when you ask about their periods are a little bit irregular, and then you see they have either beards, they have hair in the chest, then their voice is a little bit deep, then you have to now look out and see what else do they have, so that you know that they have any other hormonal disorder. So potential complications, we have things like cardiovascular disease, like diabetes that can also come along. So you have to evaluate these patients. Still, you have to do their hormonal profile. You have to test the level of testosterone. You have to test the levels of DIAs, and then also the 7-hydroxy progesterone. And in addition, if you are assessing for hyper you have to also assess their cortisol levels to see whether there's anything that is also not moving well in that area. Then you have also to do a bone age X-ray in prepubertal cases, and then see what is also going on. So you can also have if you have like elevated DIAs, for example, if it is about 4,000 to 8,000 nanograms per mil, then you can think about a possible congenital adrenal hyperplasia. So in this case, you can now do something to try and inhibit this production of hormones. So in this case, you have to manage these patients together with an endocrinologist such that they get the best care. Then if someone has high testosterone or and then the DIAs is normal, in this case, we may think that it is an exogenous source, which can either be the ovaries, and oftentimes it is PCOS that you are dealing with. So if someone has a high luteinizing hormone and follicle stimulating hormone ratio, so that usually is indicative for PCOS. And symptoms can include irregular cycles, obesity, insulin resistance, and then the acne and the male pattern distribution of hairs that we usually see in PCOS. Then other genetic syndromes with acne, you can have Apert syndrome. So in Apert syndrome, you'll have severe acne. Then you have cyanostosis, and then it is due to the FGF2 mutation, and the treatment may include, you can also give isotretinoin. And then you also have the boron dermatocardiovascular syndrome. So in this case, you have your acne conglobata, you have skin thickening, and then also vertebral abnormalities, as well as heart disorders. Like you can have some congenital heart conditions, like maybe patent ductus arteriosus and the rest. So in this case, in this syndrome, we have skin, heart, and then the skeletal muscle involvement. So in Apert syndrome is an autosomal dominant disorder which presents very early in life with cystic acne. So the acne sometimes extends beyond the typical sites. So it will affect the arms, the buttocks, the thighs, and it's also associated with the skeletal disorders, seborrhea, nail abnormalities, and then as well as the diffuse pigmentation changes. We will say that the mutation in Apert syndrome is fibroblast growth factor receptor 2 gene that is involved in keratinocyte proliferation and then sebaceous gland function. That means that they will give you a lot of sebum production. So oftentimes we treat and it is a little bit resistant, but you can try isotretinoin, which can give you some type of relief. So in the boron dermatocarditis syndrome, this one is an autosomal recessive condition caused by a mutation in the SH3PXD2B mutation. So in this case, you'll have features including dysmorphic facial features, thick skin, acne conglobata, vertebral issues, and then mitral products, or even other heart disorders. So we can have things that can give you an eruption that can look like acne. So in this case, if you have an eruption that looks like acne, we say it is acneiform eruption. So you have other things like drugs that can give you an acneiform eruption. For example, if someone has been using topical corticosteroids for long, they can get what we call a steroid-induced acne, which will also look like the normal acne that we see in the rest of the patients. Then we also have other things like drugs that have been shown to have an acneiform eruption. We can have other things like the bromides, as you can see in this table. We can have anabolic steroids for these people who go for gym and then they're exercising, they want to build muscles, then they end up using anabolic steroids like danazol or even testosterone. So at the end of it all, they end up with acneiform eruption. Other things like bromides, corticosteroids, corticotropin, iodides, even isoniazid, this anti-TB medication, lithium, usually used to manage psychiatric disorders, then phenytoin, and progestins, all these can give you acneiform eruption. So other uncommon things like quinidine, like tumor necrosis factor inhibitors, vitamin B6 and B12, all these can also give you acneiform eruption. So in this case, when you stop the agent, the acne usually goes away by itself. Then we have what we call occupational acne, or sometimes we call it acne cosmetica or pomade acne. Yeah, so in this case, it is triggered by the environment where someone works from, and the environmental triggers like either oil, like tar, people working like in construction industry, it can be in the cement or even the chemicals that maybe like the oils for working in fuel industry. So they can end up getting acneiform eruption. But now the difference will be like in this case, if someone gets this type of acne, the acne will end up covering even the ears, even behind the ears, if it is the occupational acne. So if it is the acne cosmetica, it will be where you apply your cosmetics, this powder and the rest. They will be acne will cover those areas. And then if the best treatment in this case, you avoid the trigger, and then usually it will resolve. And then we also have the chloroacne. Chloroacne is caused by the halogens or the halogenated hydrocarbons, and this is really very resistant to treatment and can also lead to scarring. So in this case, when you're managing it, someone has to stop that type of work they're doing. They have to quit their job and look for some safe areas. And then in this case, then you manage with your isotretinoin and then other things that can try and dry up these lesions. But it takes longer to manage and it's a little bit more difficult and resistant to treatment. And then you can also have acne mechanica. So acne mechanica is just because of the frictional rubs. For example, someone has maybe helmets or stripes that maybe pass behind the neck. You know, these border riders, you have a stripe that passes maybe over your chin. Then that constant friction can also give you acne. Sometimes even around the back here, you can also get acne from lesions. So acne mechanica is the differential for acne keratosis, as well as the scalp folliculitis. So in this case, you have to reduce the irritating agent, then you can use topical, even oral retinoids if there's need. So other things like the tropical acne, this is are seen in our environments in the tropics, so you have it being triggered by the climate which is a little bit hot, and it is presents with cystic acne, especially on the trunk and the buttocks, those areas that are usually covered and a little bit sweaty. And frequent times there's a secondary infection of the staph areas, and the treatment uh, it can be a little bit resistant to treatment until when someone returns to cooler environments, and then they will be okay. So it commonly affects people who are maybe commonly residing in either subtropical or temperate regions. Then they visit the tropic maybe as tourists. Then because of the heat that we have, then they end up getting this type of acne. Then we can also get what we call radiation acne for people working in X-rays and that type of and radiology settings. And in this case, they'll have acne that will look like comedons, but then this time around they'll be like papules, and they'll be in areas that were exposed to ionizing radiations. So this is thought to be due to follicular epithelial metaplasia that is induced by the radiations, and in this case, the lesions will form in areas where you had the radiation exposure, and after a short period of time, they will usually resolve. And this also shows you that there's a risk of developing radiation dermatitis. So after the acne has gone, then you can end up with radiation dermatitis. Then after that, you can actually even end up with what? With a malignant transformation in that area. Then you also have what we call the pseudoacne of the nasal crease. So in this case, someone will have the non-hormonal comedons, cysts or even melia on the nasal crease, commonly seen in children, and then in this case, treatable by mechanical expression or even topical retinoids. So in this case, you will see it along the nasal creases in this area and this area only. Then we also have what we call the idiopathic facial aseptic granuloma. Someone will present with a painless nodule, especially in young children. If it's commonly seen on the cheek, possibly it has been related to childhood rosacea, and it will resolve by itself within a period of about 1 year. Then you also have what you call the childhood fracture comedons. In this case, someone will have double olive comedons localized to the axilla and the groin, typically isolated and are not linked to other acne conditions. So these ones will give what you call acneiform lesions. So when you see this, you need to make sure that you're not dealing with either acne, or when you see acne, you have to make sure that you're not dealing with any other acneiform eruption. So when you do histology for acne, you remember it is a follicular process, meaning that your focus will be around the hair follicle. So you'll have infiltration of either neutrophils, lymphocytes around the hair follicle, with a destruction of the normal morphology around the hair follicle. So in early lesions, or when you're looking at microcomedons, which is the earliest set of stages of forming acne. So in this case, you'll have a mildly distended follicles filled with the keratinocytes and then prominent granular layer. Then when you have closed comedons, you will see on histology, you will see distended hair follicles forming cyst structures with keratin, hair debris, and also bacteria inside. And then if it is open comedons, you will see now still expanded follicle opening with the atrophic sebaceous glands, and then mild perivascular mononuclear infiltrate around the follicles. Then if it is later on, where you have a rupture and then inflammation, you will see a cystic setting having either keratin, hair, bacteria, rupturing into the dermis, surrounding epidermis with a strong inflammatory response, having neutrophils, and then this can progress to form new granulomatous inflammation. So as you can see in this histology slide that I have here, so let me magnify. So in this histology slide that you have here, so this is the arrangement. This is now the hair follicle. This is how it's supposed to exit here. here through, but then you see all these inflammatory cells that are within the hair follicle. And then if you zoom in more, you even see a little bit of these are lymphocytes predominantly, and the inflammation is only around the hair follicle. So that is how acne will look like on histology. So what are the different differentials? So the differentials are very, very many. So anything that can give you uh, something looking like a papule, something looking like a pustule, something looking like a nodule, a cyst. So all those become differentials. So now then you go by location. Any swelling on the face, acne becomes a differential, or other things that can cause something similar become a differential. So if it is closed comedones, you can have things mimicking it like milia. You can have other things like syringomas. You can have colloid milia. You can have follicular mycosis fungoides and the rest. If it is acne vulgaris, or the inflammatory type, you can have rosacea, demodicosis, and the rest. So all these are different differentials depending on how your acne lesions look like. So this is just a continuation. So for the differentials, you just need to pause the video and then take a look at each lesion. So how do we manage acne? So importantly, when you're managing acne, you have to first classify it. Is it mild, moderate, or is it severe? Or is it inflammatory or non-inflammatory? And remember what you said is that you said that the non-inflammatory acne is what we call comedonal acne. So in this case, you'll have only open and closed comedons on the skin, so you don't have a lot of signs of inflammation in that case. So if it is mild acne, you can start with a topical retinoids. So remember, they have comedonlytic effect. So in case someone has not responded to the topical retinoids, you can now add a topical retinoid together with salicylic acid or even azelaic acid. So if in case it's very severe, you can even do comedone extraction. So that is for the mild type or the comedone type. But in case someone has the papules and pustules, you need to add on now an antibiotic and try and dry these papules and pustules. So you can add the benzoyl peroxide together with the topical retinoid. So alternatively, you can add that with still azelaic acid or even salicylic acid or even the topical dapsone. And then in this case, you have to make sure that if it is recurrent and what, you have to make sure it is not a gram-negative folliculitis or even a fungal folliculitis, the one we call pitosporum folliculitis. So that is for papular acne. Then, if it is moderate, in this case, you'll have papules and pustules. You can add on an oral antibiotic like doxycycline if someone is safe with it. Then you can, on top, add the topical retinoids and the benzoyl peroxide. And sometimes you can even combine that with a topical antibiotic. For example, you can do benzoyl peroxide in the morning. Then in the night, you can do the topical retinoid together with the clindamycin. So then on top of that, you can now do the oral antibiotic like doxycycline, azithromycin, or even septrin. Then in case someone has hormonal issues, you can add oral contraceptives. Then you can as well do comedonal extractions and then the rest. So if it is now a severe type of acne, so now it is maybe nodular, and then you need to add on oral isotretinoin. And alternatively, you can also have to do contraception in case someone has hormonal contribution. So if it is the acne conglobata or fulminans, the first line you have to start with the isotretinoin. And if it is fulminans, you usually start with the oral or IV, even corticosteroids, so comes out the inflammation, after which you can start low dose of isotretinoin, then you keep increasing the dose until when you get the desired effect. So this is how we manage, and sometimes you can end up even giving interlesion corticosteroids in case someone has very big nodules, cysts, and the progression is very, very bad. So the intention of this treatment plan is to know which type of acne the patient having and how do I go about it. And remember, if it is the neonatal acne, which is due to the Malassezia species. That one, manage it with an antifungal, ketoconazole 2%. Thank you very much for watching. I encourage you to share, subscribe, and see you in the next video.